So in the CARTITUDE-2 trial, Cilta-cel, which is a BCMA-directed CAR T-cell product, was actually used in patients with different lines of previous therapy. The data that were really presented was the CARTITUDE-A cohort, which are patients with a progressive multiple myeloma after 1 to 3 prior lines of therapy, including a PI and an IMiD, and being lenalidomide refractory. And it was not allowed that the patients were exposed to a BCMA targeting agent. And the endpoints were overall response rate, duration of response. And again, the overall response rate was extremely high, nearly 100%, a very high rate of complete remissions, beyond 60%. So again, Cilta-cel was shown to be an extremely effective treatment in patients with advanced multiple myeloma. The follow-up is clearly too short to actually get a feeling about the potential progression-free survival, but the data look also really promising. And we know from CARTITUDE-1 that the 12 months progression-free survival is beyond 75%, and this was we were more heavily pretreated patients. So I think Cilta-cel is a very interesting product to be used in the treatment of patients with pretreated, relapsed refractory multiple myeloma. Another issue was the neurotoxicity that occurred in a rather small proportion of patients in the CARTITUDE-1 trial. There was especially some patients that developed delayed neurotoxicities, and they had a specific form of neurotoxicity, which was a kind of neurocognitive Parkinsonian-like syndrome that developed quite late after CAR T-cell infusion. So there was a new strategy now introduced, a kind of mitigation strategy. A part of this mitigation strategy was to define patients at high risk of neurotoxicity. These were patients with high tumor load, with a prior grade 2 or higher CRS, a prior ICANS, and also patients with high CAR T-cell expansion and persistence. And it was introduced that now these patients were allowed to receive a more effective bridging therapy, so to reduce the tumor load at the time of CAR T-cell infusion. Also, there was an aggressive treatment for CRS and ICANS, and in patients at high risk, handwriting assessment was performed for early detection of neurotoxicity, and an extended monitoring and reporting of neurotoxicity was improved. A specific ICA assessment tool was introduced where the patients were kind of assessed for orientation, naming, how they could follow commands, again, handwriting, and their attention capacities. And with this, introducing this kind of early screening and early intervention, severe neurotoxicity and this late neurotoxicity that was seen in a few patients in CARTITUDE-1 could be completely prevented in these 20 patients treated in the CARTITUDE-A cohort. And in addition, in other patients, also in these different CARTITUDE-2 trials, also severe neurotoxicity and late onset neurotoxicity could be prevented.